The first abstract that I would like to highlight, though, comes from New York. They did a prospectively treated 85 patients who underwent inflatable penile prosthesis surgery utilizing a preoperative anesthetic block. The block consisted of ropivacaine, lidocaine, bicarbonate, and dexamethasone. 97% of those patients were discharged home on postoperative day 0 without opioid prescriptions and instructed to use Tylenol and NSAIDs for postoperative pain control. And during the 30-day follow-up period, 88% of their patients did not require opioid prescriptions for adequate pain control. In the setting of the current opioid crisis in the United States, where over the last 15 years, overdose deaths secondary to opioids have more than tripled, I really want to commend these gentlemen for the work that they did towards a solution and knowing that we can all do better in this realm. Moving on to the topic of hypogonadism, there were some interesting correlations drawn between sleep disorders and the incidence of hypogonadism and erectile dysfunction. Looking at 2,500 men screened for hypogonadism, 766 of them who worked non-standard shifts had worse hypogonadal symptom scores in a validated questionnaire, and their non-standard shift work was an independent predictor of lower serum testosterone. On that same note, while looking at penile Dopplers, obstructive sleep apnea correlated with increased venous leak. And in the TRICARE database, when looking at men between the ages of 18 and 65 diagnosed with hypogonadism, on testosterone replacement, when matched for a control, the patients on testosterone did have a modest improvement in cardiovascular-free events, but did have a higher risk of obstructive sleep apnea. On the basic science side, poster 81.4 looked at using human testicular tissue. They were able to differentiate the Leydig stem cells in vitro, and then xenograph those under the mouse skin to show that they increase serum testosterone in the setting of orchiectomy to preserve the pituitary gonadal axis. This may have potential future human application in patients who are requiring bilateral orchiectomy. We have good news on the topic of erectile dysfunction for cyclists. An internet-based survey recruiting more than 3,900 men, dividing them between athletic non-cyclists, avid and non-avid cyclists, saw no deleterious effects in erectile dysfunction. However, there was a trend towards urethral strictures in cyclists, and increased time standing and higher handlebar height had a decreased risk of numbness. The news was almost as good for women cyclists. Using the same survey model, they were able to enroll more than 3,100 females, and there was no difference in the mean storage and voiding subscores or the total IPSS score. However, when adjusted for age, there was a higher ratio of self-reported UTIs. Back to good news for men. Looking at post-prostatectomy or stretched penile length, Podium 4910 enrolled 102 men. They measured stretched penile length preoperatively, 10 days postoperatively, and then at various intervals up to 24 months. The initial loss of length was seen at 10 days, but recovered fully by 12 months. These men also received a pelvic MRI at 10 days and 12 months postoperatively, which showed a vertical repositioning of the membranous urethra by 4 millimeters, but that had recovered at the 12-month image. On the prosthetic side, I'd like to congratulate Drs. Lee, Colombo, and McVeary for the work they're doing on a nickel titanium alloy prosthesis, where they're able to create with their 3D printer. It's activated by change in temperature, and while they're still in the prototype phase, their study demonstrates safety and feasibility. 3D printing allows for the device to be customized to the patient, and activation only changes with the temperature of the surrounding tissue by 4 to 5 degrees. Staying on the topic of implants, the Mayo Group looked at the risk of infection in IPP revisions, showing that at your first revision, you start at a 6.8 risk of infection, but by the time you get to your 5th revision, you have a 100% risk of implant infection. Dr. Wilson's group looked at the 43 patients with implant infections in their series of 1,000 and saw that 30% of them grew gram positives and 47% of them grew gram negatives, which is in contrast to the historical values of 77 and 20% respectively. The idea of high infection rate in the immunocompromised population was also challenged, looking at 32 HIV patients, only 2 had infections, and 26 transplant patients in a cohort from Cleveland Clinic had 0 infections. This was an interesting topic, the mini-Jupette graft. In gentlemen who have post-prostatectomy erectile dysfunction with concomitant mild stress urinary incontinence or climacturia, who were undergoing an inflatable penile prosthesis insertion. They had a mini-Jupette graft which was sewn to the medial edges of the corporotomies. The sling tightens as the prosthesis inflates, compressing the urethra, and this promising procedure demonstrated 86% resolution of climacturia and 88% resolution of mild stress urinary incontinence. I'd also like to give some attention to the group from San Antonio, who looked at the tough cohort of patients, including 13,000 men from Iraq and Afghanistan who were injured. Specifically looking at the 519 men with GU injuries, they had higher injury severity scores and more likely to have urinary and sexual dysfunction. But the disheartening part was when they transitioned their care to the Veterans Health Administration, only 3% of those patients were receiving treatment for those conditions. Finding 86 men out of that same cohort with severe penile injury, trying to identify potential candidates for penile transplant. But after excluding patients who received massive transfusion, pelvic fracture, colorectal injury, lower extremity amputation, and traumatic brain injury, they only had 17% of them remaining who would be eligible for transplant, and many had already had conventional reconstructions. So while the idea of finding the ideal candidate for transplant of the penis is out there, the reality of it is quite tough. Moving on to ejaculatory dysfunction. IX-01 is a selective oral oxytocin receptor antagonist intended for the treatment of men with lifelong premature ejaculation. In an 8-week double-blinded placebo-controlled study, they looked at on-demand IX-01 400 and 800 milligram doses taken 1 to 6 hours before intercourse and showed a 3.6-fold increase in improvement, higher improvement of the 800 milligram dose for intravaginal ejaculatory latency times. And finally, let's move on to Peyronie's disease. Looking at 10 abstracts discussing early outcomes of injectable collagenase, Clostridium histolyticum, we saw no variation in race, no increase in adverse outcomes when used off-label in the acute phase, no improvement when used in adjuvant with a vacuum erection device or penile traction device, and then when surveyed, many urologists were actually using this off-label for ventral curvatures in the active phase of Peyronie's, and all patients were doing home modeling. This interesting study sequenced the genomes of a father-son duo who both have Peyronie's disease and Dupuytren's and identified 150 SNVs, showing genetic alterations in the pathways involved in collagen deposition and cell proliferation and inflammation, as well as GI epithelial maintenance. This has never been done before. And there were 2 elegant presentations about dystrophic calcifications in the Peyronie's plaque, which helped us to better understand the origin and the composition. The composition had a high calcium to phosphate ratio similar to hydroxyapatite found in bone, and micro-CT shows that this calcification sits between the longitudinal and the circular layers of the tunica albuginea. The second study more focused on the porous structure, that it was similar to that of the branched venous structure at the interface between the albuginea and the tunica. And finally, I'd like to say